also perilunate dislocations as well. Okay, all right, guys. So we know, right? Well, like we talked about on Tuesday before the break, right? We know that there are a lot of muscles that cross the forearm that ultimately have their insertion either near the wrist, like on the second metacarpal, right, and or on like the base of the fifth metacarpal, and or on the tendon sheath of the hand. So we went over obviously the main extensions of the forearm. We know those to be, excuse me, the extensor carpi radialis longus and brevis, the extensor digitorum communis, the EDM or extensor digiti minimi, and the extensor carpial narrows, so the ECU, right? So we know those insertions. We know that the ECRL inserts on the base of the second metacarpal. Okay, the ECRB or the extensor carpi radialis brevis inserts on the base of the third, right? And then the EDC or the extensor digitum communis, the extensor digitorum communis rather, inserts on the inserts on the second through fourth metacarpals, right? And then the EDM inserts on the fifth digit. And then obviously down there we have the ECU inserting on the base of the fifth, right? So we know about the extensors, right? By the way, there's a muscle here and it's labeled, it's colored orange, right? And it's called the anconeus. Who can remind me what the anconeus does? What's the anconeus do?
Does it help pronate or supinate? One of them?
Close. Not quite. Close, though. Okay, so you guys remember, right? The anconeus actually lies just distal to the tricep, right? And it helps us. So the tricep, remember, is going to take us. It's going to complete the vast majority of the elbow extension that we possess, right? But additionally, that anconeus is going to take us those remaining 5 to 10 degrees of extension, right? So the anconeus completes elbow extension. Okay. Okay. So the flexor compartment of the forearm, so the flexor mass, right? A lot of these muscles obviously also cross the wrist, right? If I could spell, holy cow. The flexor carpi radialis, right? So it originates on the medial epicondyle, and then inserts on the base of the second metacarpal, right? So then we have, obviously, we talked about the FCU. Okay, the FCU, as we talked about, has more than one origin, and obviously also more than one insertion, right? So that we know that the flexor carpi ulnaris has its origin on the humeral head, okay, medial epicondyle, olecranon, and posterior ulna, and then inserts distally on the pisiform, hook of the hamate, and the fifth metacarpal, right? So, and then we obviously have the palmaris longus, right, that originates on the medial epicondyle and inserts on the flexor retinaculum and palmar aponeuroses. And a cool way to, obviously remember if you want to find the palmaris longus tendon, take your thumb and your fingers and put them together. And if you look at your forearm, you'll see a little tendon pop out right below your thenar eminence. That is your palmaris longus tendon. Commonly, that is actually used as a graft for UCL reconstruction. And there are people, though, that don't have a palmaris longus. And then in that sense, we're talking about the UCL of the elbow. They'll use the hamstring tendon to do that. Okay, so all of these muscles obviously are innervated by the median nerve, right? By the AIN, which is the motor branch of the median nerve. Okay, whoop, wrong direction. Okay, the thumb, we talked about this, okay, movers of the thumb. So we have obviously our thenar muscles, and we remember the difference between the thenar eminence, okay, right? The big meaty thumb side, right? The muscles there, okay, those are our loaf muscles, okay? The opponent's pollicis, the adductor pollicis, and the extensor pollicis, right? So obviously the abductor pollicis, flexor pollicis, and opponent's pollicis, they're innervated by the median nerve, okay? And then obviously we have our EPL and EPB, right? So that common tendon, and then the APL, the abductor pollicis longus, right in the middle of those is my snuff box, my anatomical snuff box. And what lives in the anatomical snuff box?
Scaphoid.
Scaphoid, got him. Okay, so obviously the EPL, EPB, and APL, they're innervated by the PIN. So remember the posterior interosseous nerve. Okay, we check that via the thumbs up. Okay, so the terminal branch of the radial nerve, terminal motor branch of the radial nerve. Uh, okay, so obviously then, okay, we know that, but what about obviously the muscles on the lateral aspect of the hand? Okay, I'm sorry, on the medial aspect of the hand, at the ulnar aspect of the hand. So we have the abductor digiti minimi, okay, the flexor digiti minimi brevis, and the opponens digiti minimi brevis, and those are all innervated by the ulnar nerve. Okay, so hypothenar side, okay, flexor digiti minimi brevis, okay, digiti minimi abductor digiti minimi, right, and opponens digiti minimi, okay, and those are C8 and T1, so that's ulnar nerve. Okay, any questions? I know that we went over this last week, but I wanted to review this because I know that Kai was driving and Charlie, you had other things that you needed to take care of. So, any questions about this, guys? I know this is probably pretty self-explanatory. We good so far?
Good.
Bingo. Okay. All right. So here's the deal: the hand intrinsics. Okay, this was my.
Hey, Wade.
Yeah.
1 second. Charlie has a question.
Charlie, what's up, dude?
Sorry, my microphone's not working.
That's okay.
So I know the thenar muscles are
Yes, sir.
mean thumb. But does the pollicis, does that also mean thumb?
Yes. I'm sorry. I should have explained that. Yes. So pollicis is another word for thumb. That is correct. Yep.
Oh wait. Perfect.
Yep. Bingo. Nice. All right. Thank you, Izzy, for letting me know. I would have totally not seen that. Okay. Thank you. All right. Cool. Hand intrinsics, friends. Okay, so we're talking about three groups. We have the dorsal and palmar interossei muscles, right, and then the lumbricals. So these hand intrinsics, obviously, as we know, are innervated by the ulnar nerve. Okay, so T1, right, and this obviously actually helps us. Okay, if you notice, if I take my PIP and I flex it, and then I try to extend my MCP, so that's my dorsal and palmar interossei muscles actually contracting to extend my MCP joint. Pretty crazy, right? And you can actually see where they attach. They actually attach the base of the proximal phalanx. So, right, if I am essentially extending and flexing, right, my MCP joints, that is my dorsal and palmar interossei. Okay, now we know that there can be obviously with ulnar nerve compression, there can be definite atrophy of these muscles. And if we know, if we're very careful and we do a careful inspection, we can actually see at times atrophy of these muscles because the web spaces themselves look very atrophied and almost kind of like sunken in, right? And kind of wasted. Okay. All right. I know I'm moving kind of fast, but okay. Before I go to the next slide, I want to ask you guys a question. And I know that this was not, we talked about it, but I know that it can be kind of confusing. What do you guys remember about the pulley system of the hand before we go to the slide? What do you remember about it?
So like the tendons go all the way through all three phalanges, and they're like strapped in.
Okay, they're strapped in. Okay, I like it. Okay, yep, you're right.
That's pretty
and
common terms to describe it by, but
no, you're right. No, I mean, Bennett, you're right. So the pulley system of the hand, remember, guys, as we talked about, okay, the pulley system of the hand is meant to guide the tendon as it flexes and extends the finger. Okay, so if you remember, right, when you see the letter A, okay, that simply means annular pulley, okay, or like in a circular pattern. Okay, we're going to learn about a structure in the spring called the annulus fibrosus when we talk about disc herniations of the spine, right, for the lower back and neck, right. There's a structure called the annulus fibrosus that surrounds the inner part of the disc. And we call it the annulus because it's a circular structure, right? It's circular and thick and fibrous, right? And tough, right? So we have this annular, okay, pulley, okay, and those are labeled here, A1 through A5, okay? So if you think about kind of where these pulleys are going to lie, so we have A1, okay? A1 is going to be right down at the MCP joint. A2 along the shaft. Okay, basically the shaft of the proximal phalanx. A3, okay, going to be right at the joint. Okay, right, essentially right at the IP joint of the PIP joint rather, excuse me, of the finger, right? A4, okay, right along that middle phalanx, and then obviously A5, just distal to the joint on the DIP there. So if we remember that those A pulleys, right, are meant to provide a tunnel for the tendon to slide through, okay, as it essentially flexes and extends, right? So that's what the A pulley does. Conversely, okay, the C pulley, okay, those cross, so they're like little X's, right? And the function of the C pulleys, C1, 2, and 3, right, is to keep the tendon from essentially gliding medial to lateral, right, as the finger flexes and extends, right? So those are essentially top bands of fascia that you guys will see. And so, um, yeah, and we'll talk more about when we talk about finger tendon injuries soon. You know, you guys will actually this will make a lot more sense as well, because oftentimes with finger tendon injuries, these pulleys can get disrupted in it, you know, as well. So, okay, now there are also pathologies that we'll talk about where the pulley itself actually becomes inflamed, and the tendon sheath under the pulley actually gets essentially inflamed and scars, right? And then sometimes people will have what's called a trigger finger, where the finger will become bent and they can't actually actively extend the finger or flex the finger. They have to take their thumb and essentially straighten the finger manually. They can't do it on their own, right? It's a very common presentation for something called a trigger finger, right? And patients may often describe a clicking or a popping sensation at the location of generally one of the pulleys, generally A1, but you can also see these at A3 and A5, right? Um, but generally, you're going to see these most at the MCP joints and the PIP joint, but we'll talk about that more. Okay. All right, friends. So we talked a lot. Okay, if you guys remember, we talked a lot about the lunate. Okay, and how ultimately that one of the lunate's key jobs is to help maintain and regulate carpal stability, right? So the lunate's a really important bone because the lunate essentially articulates with more bones, with more carpal bones than any other bone. So there are actually more ligamentous attachments from the lunate to other carpals than anywhere else in the wrist. Okay, so that's why it's so important. So we know that the lunate obviously articulates with the scaphoid at the SL interval, right? Uh, right, and then so we know also that distally, so distal to the lunate, we have the capitate, right? And then we have the triquetrum medially. And so all of those have attachments to the lunate. And so oftentimes, okay, when we have essentially a Fuchs injury or fall in the outstretched hand, the lunate itself can actually dislocate. And we already said, right, that the lunate is actually more stable, or I'm sorry, that the wrist itself is more stable uh, dorsally, so on the dorsal side of the wrist, as opposed to the volar side of the wrist, right? And so ultimately, we can have a lunate dislocation from a fall on the outstretched hand, but that generally only happens in the setting of multi-ligament disruption. Okay, like a disruption to the scapholunate ligament. Okay, the capital-lunate ligament. Okay, the lunar triquetral ligament, and then obviously we have the dorsoradiocarpal ligament, which is a very large ligament in the wrist that runs over the dorsal aspect of the hand from the radius to the carpal bone itself. Right. So the difference between a lunate dislocation and a perilunate dislocation is that when a perilunate dislocation happens, right, the lunate essentially stays in line with the radius. Okay, so the picture on the left here with the red dotted line through it, that is actually um, a lunate dislocation. So you can see how the remaining carpus is staying in alignment with the radius. Okay, while the lunate is actually dislocated palmarly, right, toward the hand, or toward the palm of the hand. Okay. Conversely, okay, perilunate dislocations, and this is a great example of one in the picture on the right. Okay, this is essentially where the lunate remains aligned with the radius, while the remaining carpal row dislocates around the lunate. Right, so the lunate stays fixed, and the carpal row dislocates around it. Here's the deal, guys. If you have someone that has considerable carpal deformity after a fall in the outstretched hand, and you notice maybe even a little bit of deformity uh, with the height of the metacarpals, then I would go ahead and send that person for an X-ray to make sure they didn't dislocate their lunate, right? And you may notice as well, kind of a palpable step off at the carpal row in people that have lunate dislocations. And so if you suspect it, we need to get these people splinted and get them over to the ED for imaging and reduction. Okay. Any questions about the lunate before we jump about lunate injury before we jump into the TFCC?
So the lunate dislocation is solely the lunate getting out of place, and the perilunate is when all the other bones in that carpal row are out of place.
That's correct. Yes. So yeah, with the lunate dislocation, the lunate dislocates, okay, and the carpal row stays in alignment with the radius or fixed, right? But with the perilunate dislocation, right, the lunate stays fixed and the carpals dislocate, over the lunate while the lunate stays in place. Yes, absolutely correct. Okay. Any questions about that? Okay. All right. TFCC, friends. This is a big one. Okay. So the TFCC, this is one of the most complex structures in the wrist, right? So much so that the anatomy of the TFCC is actually still being studied, right, and explained. So the triangular fibrocartilage complex, or as we abbreviate it, the TFCC. Okay. This is a very complex structure that actually is a combination of the ligaments of the ulnar wrist, right, cartilage, and as well as obviously the extensocarpionaris tendon. So you remember how we talked about in class yesterday, right? How the ECU sometimes can also be injured with a TFCC injury, or excuse me, TFCC injury can be sometimes confused with ECU injury. The reason for that, guys, is because the ECU is so incredibly confluent with the TFCC that oftentimes they're either they go together, right, as far as injury goes, or the symptoms essentially are extremely similar simply because of the anatomical location. So when we think about what makes up the TFCC, okay, so this is a combination of ligaments. So the superficial dorsal and volar radial ulnar ligaments. So those are a big part of the DREJ. Those naturally run in a transverse fashion across the DREJ to stabilize it, right? So if you look, okay, if you look at this picture, okay, the one thing you'll notice is that on either side of the ligament here, okay, and I'm going to show you a better picture here in a second. You see this kind of this gray disc that sits on the inside of the ligament. Okay, this is actually what we refer to. It's called the cartilage disc, and or the meniscus homologue of the wrist. So we can actually think of the TFCC as the meniscus of the wrist. Okay, to kind of use a kind of a crude comparison, but that's how we can think of it, right? So the TFCC, as we know, is loaded into compression, right? It takes compressive loads just like a meniscus does, but diagnosis of a TFCC injury can be complex. So generally speaking, and we'll talk more about this when we talk about ligamentous injuries, but these patients are going to present with ulnar-sided wrist pain, right? And ultimately there will be, generally speaking, popping and clicking oftentimes that patients will describe. But as we can see here, based on the anatomy and essentially the anatomic complexity of the TFCC, right, with the fibrocartilage disc and meniscus and the meniscus homologue, the ECU tendon sheath, and then the ligaments that connect the triquetrum to the radius and ulna, right, as well as the UCL. We can see that the anatomy here is extremely complex. So anytime that a patient has ulnar wrist pain, right, generally speaking, even a UCL injury to the wrist can sometimes involve the TFCC as well, right? So TFCC pain is so incredibly common that it's actually also referred to as the back pain of the hand, because this is actually such a common problem. Um, and we know that anatomically and biomechanically, the TFCC, as we can see, is a major contributor, okay, to stability at the DRUJ. So if somebody has, like a Fuchs injury, and they've got a really, really positive DRUJ shuck test and a lot of owner-sided wrist pain, they may, it's also possible that a TFCC tear can be included in that injury. Okay. Um, so, all right. So let's take a look at the anatomy a little bit in a little bit more detail. Okay. So here's the TFCC itself. So we can actually see, okay, how here at the ulna. So here's the ulnar styloid. Okay, here's the UCL of the wrist. Okay. Now you can see here that we essentially have the we have the radial ligament. Okay, that runs between the radius and the carpals of the wrist and the lunate specifically. But we can see here on the ulnar side. Okay, here's the articular disc, right, or the meniscus homologue, and on either side of the meniscus homologue, okay, are the superficial radial ulnar ligaments here, right? And you can actually even see that the TFCC is actually going to extend. It's going to extend actually to the medial aspect of the radius here, and it's going to provide us with that stability, right, to the DRUJ. Now, the other thing I want to point out too is you can actually see here's the ECU, okay, and the ECU here, the ECU tendon, runs in pretty nice confluence with the TFCC. For the sake of illustration, it's actually kind of been retracted and pulled back. But you can see how the ECU, okay, as we know it, runs right directly over the superficial portion of the TFCC, okay, particularly down towards that ulnar styloid. The tendon essentially runs right over the top, of the TFCC. So anytime a patient comes in with ulnar-sided wrist pain, guys, particularly after a traumatic event, TFCC injury should always be on your differential list, right? Particularly if the pain is ulnar-sided. Always have that on your differential list, and always have a high index of suspicion for that type of a problem. Okay, so any questions about this? I know that this is a little bit more complex as far as the anatomy goes. Any questions about the TFCC?
So, like, if this is suspected,
Yep.
are you gonna like send this right away, or like just because it's so complex? And
so if someone, Bennett, that's a great question. So if somebody has a TFCC injury, particularly if it's their first one and they're in a ton of pain, right? And we think that there is potentially a lot of instability, I would send this right away. Yes. If it's someone that has had this problem for a long time and it's essentially just kind of an ongoing condition that they know about, that they've had worked up previously, I don't think that there would be as much of an urgency as far as sending this person out for referral. But a lot of your acute TFCC injuries, particularly if there's considerable pain and mechanical symptoms, and you appreciate a lot of laxity on your exam, I would definitely have that. I'd definitely get them in with Dr. Fetzer and/or an orthopedist, potentially even a hand surgeon as well. Does that help?
Yeah.
Yeah, and Bennett, these injuries are notoriously complex, and it's so difficult to get these things well. People will continue to have pain with this type of a problem, and it'll just drag on and on and on. So anytime that you have someone that's dealing with a TFCC problem, particularly an acute one with significant symptoms that are really painful, I will refer it. Yep. So, great question. Any other questions, guys? Okay. All right, cool. You guys doing okay? How's your stress level? Everybody fine? All right.
Good.
Well, maybe we need to do like food or something soon, because we need to do that, because I kind of feel that in my being. that we need some time like that. So, okay, guys, I will see you on campus tomorrow. How's the weather on campus, by the way? Is it pretty nasty? Pretty sucks.
It's bad.
Yeah. Okay. How many inches do you think how many inches do you think that we've gotten on campus? Pretty bad? Hope you're muted, Izzy. I can't hear you.
3 maybe as of right now.
Okay.
Yeah, I'd say about
Depends on
three,
where they
3.5.
Yeah. It's starting to get nasty here too. It's just like, yeah, and it's gonna do this all day. Ugh. And I've got to drive later, and I'm not looking forward to it. So, all right.
Yeah, question.
Yeah. What's up?
I'm supposed to go to Shakopee, so
Here's the
I'm
deal.
allowed to be like, I'm not feeling too confident, right?
Just what I would do, just email Ashley, be like, Ashley, here's the deal. The weather here is horrible. I just don't think it's going to be a good idea for me to drive. Just let her know. Hey,
Okay.
just let her know that you've talked to me, and that if weather's a concern, and yeah, if you guys feel that you can't get to your clinical safely, then clearly don't go, because we don't want to compromise your safety. Okay.
Okay. Thank you.
Yep. All right, guys. I'll see you tomorrow. Okay.
Bye, Wade.
See you
ya.
tomorrow, Wade.
Thanks,
Thank
Wade.
you.